So it is 8 o'clock and we like to be prompt, so we're gonna go ahead and get started. Um, we have Monica Harrison with us this morning, and I've just got to tell y'all, I am looking forward to this. And Dr. Gibson and I were saying we are really, really excited to have Monica here. We know Monica. We have heard her speak many times. She does a phenomenal job doing trainings and holding monthly office hours with the Ames Center. And so she is a well-versed, experienced um, COCM presenter and has done this work herself. So we are so grateful that you are here, Monica. And I'm going to uh, just do a quick introduction and then we're going to turn it over to you. But we've got Monica Harrison here. She has been providing behavioral health services to individuals since 2003 in medical, educational, and community-based settings. She also has extensive experience working with young children from her prior years of working with Head Start and Early Head Start programs. Monica spent several years as a clinical leader working on teams in inpatient and outpatient behavioral health, nephrology, group homes, specialty medical settings, and FQHCs. Most recently, Monica worked at a large hospital system with an outpatient primary care clinics in Connecticut, providing program building and leadership similar to her time at the FQHC, and started their collaborative care service delivery program. Monica has experience with training and implementation of evidence-based integrated care models. Monica received her bachelor's in early childhood education with a special education birth through kindergarten designation. She also has a master's in social work from a joint program at a predominantly white institution named the University of North Carolina at Greensboro, and a historically Black college and university named North Carolina Agricultural and Technical State University in Greensboro. Excuse me. And as I said, we know and love Monica. We have been interacting, working with you, collaborating with you through CFHA, through multiple trainings on our COCM journey in Arkansas, and we are just so grateful you're here. I don't know if you want to add any words, Dr. Gibson. You've been working with her and know Monica as well before we turn it over to Monica.
Yes, I was just going to add in there that words don't really say enough about about Monica's credentials, but also her personality and her experience. And so we feel really grateful to have her to participate and to partner with us. She's somebody that we call for questions. And if she doesn't know the answer, which she knows most of them, but if she doesn't know, she will say she doesn't know and she will find out the answer. But especially she's fun and she's engaging and can be a resource for all of us. So welcome, Monica. We're really glad to have you here and participating in our Arkansas web.
Thank you guys. You guys make my star shine. I love it. Thank you so much. Thank you guys for inviting me to talk with you today. I bring you greetings from the Ames Center out of Seattle, Washington, at the University of Washington. I am actually in Connecticut. So some may be thinking, well, she is up at 6 a.m. That is not the case. It is 9 where I am, so I've been up for quite some time. But I appreciate the invitation. And I'm going to speak today from the Ames Center's nearly 20 years of experience assisting diverse healthcare systems in implementing collaborative care for a variety of patient populations. And to look ahead, talk some about that, about the emerging areas for collaborative care that we all may want to think about as we go on this journey together. That's what helps me. We were talking about being able to meet lots of different people and share ideas and be thought partners together. That is the part that I love about our collaborative care community. Individuals are willing to share their knowledge. There's no one expert. Like, we all have these pieces that we bring to the table. So hoping that we talk some about where we've been, what's coming up and what's going on, and have some dialogue with each other and answer some questions. So let's have at it. as I've already mentioned, who I am, and thank you, Kim and Patty, for such a great introduction. I do have to say that I have no financial disclosures to report. So almost 20% of Americans experience a mental illness, higher than in previous decades, even higher for some populations, like those with SDOH or social determinants of health needs, and those with medical comorbidities, and more than half of them don't receive treatment of any kind. So according to a national study conducted by SAMHSA, only 47% of US adults with a mental health condition receive treatment in 2021. Of those who do receive treatment, most receive care in primary care. So there's a large national study that found that over a 15-year period, the proportion of all mental health visits that occurred in primary care rose from 54% to 60%. So primary care is where a majority of the people are receiving mental health treatment for diverse mental health conditions. We have felt this way for quite some time, and the data and research supports that. Approximately 30 million patients have a prescription for a psychiatric medication in primary care, but only approximately 25% of them have been shown to actually improve. So the proportion of psychotropic medications prescribed by primary care providers have increased from 67% to 77% over just a 15-year period. And these aren't just antidepressants that are being prescribed. So that is a common kind of misconception about integrated care and collaborative care, is that it's only antidepressants that can be prescribed. So nearly all of the collaborative care trials included patients with moderately severe, and in some cases, severe symptoms. So not just the mild to moderate that we think of. And many studies, especially those conducted in the past 10 to 15 years, have examined collaborative care for a wide range of mental health conditions, not only depression and anxiety. So the reality of the current mental health system is that most patients, regardless of their symptom burden, they cannot access specialty care. That is still a concern in terms of accessing it in a timely manner. So that makes primary care kind of the go-to mental health treatment system for majority of our patients. So as hopefully most of you know and are not all new to collaborative care is a systematic approach to integrated care. So this slide shows some of the key features of collaborative care. So collaborative care starts with a primary care practice that has integrated a behavioral health provider. The primary care team is supported by regular use of evidence-based outcome measures, such as the PHQ-9 or the GAD-7. There are others. And those are used every time a patient presents for care to see if the patient is improving. They will also use a registry that helps clinicians track which of their patients are improving and which need changes in their treatment regimen. They also use evidence-based psychotherapies that are brief, structured, and are appropriate for primary care. And they review all patients who are not improving with a psychiatric consultant during what we call weekly systematic case review. Sometimes you see us write it as SCR, but that is that weekly systematic caseload review time. So just wanted to level set in case there are some individuals on who have not had an opportunity to really understand what collaborative care is before we go into our lessons learned. So this presentation is timely because this year, 2024, actually marks 20 years of collaborative care. So over the past 20 years, we have learned some key lessons about collaborative care. So I want to talk about that and kind of the future direction. So first, collaborative care is significantly more effective than usual care for mental health conditions delivered in primary care and other medical settings. So this graph shows the difference between collaborative care and usual care in the largest research trial of collaborative care that's called the IMPACT study. So those of you who have been there from the beginning, remember when we weren't calling it collaborative care, we were calling it the impact study. So there were 8 organizations that participated in the trial. 50% of the study patients use antidepressants prescribed by their PCP at the time of their enrollment, but were still significantly depressed. So the blue bars here represent usual care. So 70% of the usual care patients received medication therapy from their PCP, and they might have also received a referral to specialty behavioral health. Only 20% of the usual care patients showed significant improvements after 1 year, which matches some of the national data that was out there for depression treatment in primary care. So those are your blue bars. The green bars represent collaborative care. So as you can see, on average, collaborative care doubled the likelihood that patients improved. The difference was seen in every single one of those 8 organizations. It was even true at one clinic that had a master's level clinical social worker embedded in the primary care practice, and they were providing co-located specialty care. So receiving co-located therapy from those providers was part of the usual care, and you could see collaborative care still got twice as many people better. So this is from a different study, this slide here, that also shows the difference between co-located behavioral health services and collaborative care. So the blue bars show the likelihood that the patient achieves a significant reduction in depression symptoms as measured by the PHQ-9. So PHQ-9 scores were more than twice as likely to improve with collaborative care as compared with co-located specialty care. So it's important to note that effectively applying the principles of measurement-based treatment to target, there are 5 principles for collaborative care, and that is one. So effectively applying that can drive early improvement for patients. So based on a retrospective study of over 7,000 patients, those who were engaged in treatment through collaborative care were able to achieve remission on average in 86 days, compared to an average of 614 days of those who are in usual care. So that's less than 3 months compared to 2 years experiencing depressive symptoms. Both patients and providers are more satisfied with collaborative care as compared with usual care. So at baseline, patients receiving usual care and patients receiving collaborative care were both satisfied with their depression care that they were receiving. About 50% said that they thought their care was excellent or very good. At 3 months and then at 12 months, there was a significant difference between the patients under usual care and the patients with collaborative care regarding their satisfaction with the care that they were receiving, such that the collaborative care patients that are shown here on this slide in green were significantly more satisfied with the care that they were receiving. So the IMPACT trial found a similar pattern as well with primary care providers and their satisfaction providing behavioral health treatment. In the trial, patients were randomized at the patient level. So primary care providers had patients receiving collaborative care, but they also had patients receiving usual care. And at 12 months, PCPs reported significantly higher satisfaction with collaborative care as compared with usual care. So collaborative care, as first shown as the IMPACT trial, as I mentioned earlier, led to better access to care, better health outcomes, and lower healthcare costs. So supporting the positive results in that initial IMPACT trial, there was more than 90 randomized controlled trials. It has shown that collaborative care is more effective than usual care for the common mental health conditions such as depression and anxiety. We have some evidence-based things on our website that I've put the link here. There's about 7 different bibliographies covering everything from the foundational evidence from collaborative care, practice-based evidence things, financing, cost effectiveness, treating racial and ethnic minority groups with collaborative care, under-resourced communities, treating patients there, treating concurrent physical and psychiatric conditions at the same time, and of course, treating substance use disorders. So when you get an opportunity and you want to see some of that research that's out there, please feel free to go there. So collaborative care has evidence for treating a variety of behavioral health conditions. Hence some of the things I mentioned that there are those bibliographies on that site for. So depression for a variety of patient populations is one, but also includes adolescents, patients with cancer, patients in women's healthcare settings, or patients with medical comorbidities, multiple comorbidities that are happening. So anxiety, which is the most prevalent condition reported in primary care, PTSD, that's one as well that we'll see and that we've seen and we'll talk about a little bit. Chronic pain, there's some work by Stephen Dubsa and his colleagues there. Dementia, as described in a national academics report that was published in 2021 about treating patients in collaborative care with dementia. Substance use is another one that individuals are using collaborative care with, including alcohol use disorder or comorbid opioid use disorders as well. We've seen some of that in the Summit trial that was conducted by Kate Watkins and her colleagues. And in addition, there are 4 large research trials under the HEAL initiative that is currently underway. So they are investigating collaborative care for co-occurring opioid use disorder and mental health conditions. And then we also have some emerging evidence for using collaborative care to treat bipolar disorder, which I'll also talk about a little bit. So that was our first lesson that we've learned about all those things. Now, the second lesson that we learned is that collaborative care reduces health disparities. So although most studies show that racial and ethnic minorities experience mental health conditions at the same rate as individuals who are identified as white, there are significant disparities in access to treatment, in the quality of care, in the clinical outcomes. So this data shows that collaborative care was significantly better at achieving depression improvement in Black and Latina populations than usual care. And that improvement rates were equal to or better than rates of improvement for patients that identified as white. So the blue bars represent, again, usual care, and the green bars you see there represent collaborative care. So you can see that for all 3 groups, collaborative care significantly increased the likelihood of a response to depressive symptoms at 12 months. Then this slide shows collaborative care outcomes for the American Indian and Alaska Native patients. So the blue bar shows the American Indian and Alaska Native patients. The green bar shows patients who identify as white. And then the gold bar, hopefully it's showing up gold because sometimes when you're looking at it, it looks yellow. But the gold bar shows patients from all other racial ethnic groups. And then there's the black bar that shows all the patients combined together. So the left set of bars show the proportion of patients experiencing a depression response. The right set of bars show the proportion of patients experiencing depression remission. So in both cases, the American Indian and Alaska Native patients were slightly more likely than the other groups to have a clinical response. So this difference is not statistically significant, but what is significant is that they achieved outcomes comparable to other groups where they typically experience significantly worse symptoms. Here is a systematic review of 19 studies published in 2020 that looked at collaborative care delivered to a mix of patients from different racial groups. So the study included, all of the studies included 10 randomized controlled trials and 9 observational studies that all included those 5 key principles of collaborative care. One of the challenges they encountered is that there was no kind of standard definition across all of them for cultural sensitive care. However, the review did show that collaborative care, even without the cultural or linguistic adaptation, was still effective at improving depression symptoms for racial and ethnic minority patients, including patients with incomes below the federal poverty level. So that brings us to lesson 3 of what we learned is that collaborative care can result in cost savings. I like to say we are in healthcare, and healthcare is also still a business. So of course, individuals want to know, is there some cost savings? Can we just break even? Those are always the conversations that are had as individuals are implementing collaborative care. So in this slide, we compare healthcare cost over 4 years in patients enrolled in a collaborative care program to those receiving usual care. So the dollars shown here are in 2002 to 2004, and they come from that IMPACT trial. So in the first year of analysis, collaborative care patients cost $522 more than usual care patients. And then by the end of year 2, the extra cost was eliminated by savings with the collaborative care group as compared to the usual care patients. So then in years 3 and 4, the cost savings continue to accrue for the collaborative care patients, even though they didn't receive additional collaborative care. So ultimately, the collaborative care patients had significantly lower healthcare costs across all 5 cost categories. And the result was a return on investment of $6.50 for every $1 spent. So looking at it another way, basically the cost for collaborative care patients was an average of $70 per member per month, lower than those receiving usual care. There was a meta-analysis published in 2012 that reported on data from 22 studies conducted over a 30-year time frame. So most of the studies showed collaborative care cost savings. One study compared demographically similar clinics in which some clinics were using collaborative care and the other clinics were practicing usual care. So while healthcare costs increase for both groups of clinics, over the course of the study, the collaborative care clinics saw only 73% of the increase that was seen in usual care. Plus, the collaborative care patients were less likely to use the ER and less likely to use inpatient psychiatric care. Then we had a report published in 2018 by Melick that showed that integrated care resulted in better patient outcomes and was cost effective. That was a benefit that was reaped by payers. He concluded that there is a clear potential for healthcare expenditure savings through effective integration of behavioral health care with medical services. So that's integrated care in general. So as shown in this table from the report, the cost savings was between 38 million and 68 million across all payers and represent 16% to 28% of all spending for mental health and substance use services. So then we had commercial payers who adopted the collaborative care CPT codes, and commercial payments for the codes have grown to be significantly higher actually than Medicare payments over this last 3-year period from about 2018 to 2021. And as you can see from the graph at the right, the ratio of commercial to Medicare payments for collaborative care and general BHI or behavioral health integration codes increased from 125% in 2018 to 150% in 2021. So we know from our work with diverse healthcare organizations around the country that the financial viability of collaborative care can be significantly influenced by your payer mix. And that's what's much more challenging for clinics that may have a larger Medicare, Medicaid population as compared with clinics who may have patients with more commercial insurance. This shows a Pay for Performance initiative. So it was over 100 community health centers in Washington that implemented collaborative care with support from the managed Medicaid plan. After a few years, this plan made 25% of the payment the clinics receive dependent on performance on 5 key quality metrics. It was 5% that they got for each metric. So this graph shows the median time it took for patients to achieve a 50% decrease in depression symptoms from baseline. So the blue line there shows the length of time during that time before the Pay for Performance initiative. And you could see that it took about 65 weeks, so well over a year. And then the red line shows time to improvement in the year following the implementation of the Pay for Performance initiative. And you can see that that time to improvement was reduced to 24 weeks. So lesson 4 that we learned is that the primary care provider or treating medical provider, because we do have individuals doing collaborative care that aren't in just a traditional primary care setting. What we've learned is that primary care providers absolutely are essential to the effectiveness of collaborative care. And so that engagement with them, people usually focus on the behavioral health provider when we start talking about integrated care and integrating behavioral health providers into medical settings. There's a big focus sometimes on those behavioral health providers in the model. And we don't give enough attention to the importance of the PCP. So the importance of the primary care provider in collaborative care cannot be overstated enough. The PCP is absolutely critical to the success of collaborative care. First, this is a primary care model. That's what the research was founded off of. And in our experience, when collaborative care ignores the key role of the PCP, it significantly undermines the effectiveness and the sustainability of the collaborative care service delivery. So the PCP needs to understand their role, of course, and how it's different from usual care. They also need to understand how collaborative care will work in their clinic, the eligibility criteria, and any specifics of the workflow, so that they can effectively communicate about it with patients and support the team as a whole as they work with the patient. So a strong endorsement from the PCP can mean a lot when it comes also to patient engagement, which we also know is another big indicator of sustainability and outcomes. So a great deal of thought is often given to how the behavioral health care manager and the psychiatric consultant will perform their roles and work together. But sometimes we give less attention to the PCP and the engagement of the PCP in the treatment team. So it's essential that the behavioral health care manager understand the type and frequency of communication that's preferred by each PCP, because each one is very different, and how much communication and how they like to receive their communication. So they need to be able to tailor that communication according to the PCP. It's also important that the PCP know where the treatment recommendations are coming from and have confidence in the psychiatric consultant that's providing them. We've seen this sometimes be an issue, just quite honestly, when the PCP is a physician and the psychiatric consultant is a psychiatric nurse practitioner. We've sometimes seen there be an issue. So these are things that you just need to know what the issues are and have open conversation and dialogue about them so that you can address them and not pretend like it's not happening or that it doesn't happen. That's why I'm like, just to be honest, it happens. And so you want to just be able to address those issues and concerns as they come up. So one barrier to effective implementation of collaborative care is that the PCPs may not necessarily want to be a part of the treatment team. We've seen this happen. They may prefer to refer their patients to specialty care so that they can just focus on the medical conditions. They don't want to focus on any of the behavioral health conditions. So it can be hard to address both physical and mental health conditions in a 15-minute appointment. So I don't fault anyone in that. It is challenging. So we need to know that effective implementation of collaborative care means addressing any of the concerns that the PCP may have so that they can engage fully in their role as part of the treatment team. So there was a book published in 2017 that showed PCP perceptions of collaborative care, and it gathered it before and after implementation. So some common concerns are shown here on the left and include fear that collaborative care is going to be a burden on them, and confidence that they don't need support to effectively treat mental health conditions. PCP perceptions after collaborative care implementation are shown on the right. So this is one of the reasons why a PCP champion, we talk about creating a clinic implementation team when you're going to embark on providing collaborative care as a service in your clinic. And a part of that clinic implementation team, we call it CIT for short, is having a PCP champion on that team. So they are important for when you are planning collaborative care, providing collaborative care, and the implementation. So not to just wait until after you've kind of launched to then include them. They really need to be on the front end, a PCP champion that is involved. So the PCP champion is the one who can promote the model to their peers and who serves as part of the implementation team that plans some of the clinical workflows. So you want to have workflows before you do implementation. So they would be a part of that. Also a part of other organizational level support of implementation that might need to happen. So you need a PCP who is open to collaborative care, willing to be a part of the vanguard and the push forward in the transition that your clinic is having, and able to support their colleagues through the implementation and sustainment process. The fifth lesson that we learned is that articulating quality metrics and using the metrics for regular program monitoring and adjustment is key to a successful collaborative care program. So it can be helpful to map metrics to the 5 key principles of collaborative care. So the 5 principles, because I just realized I've been mentioning them and probably should have put them at the front. The 5 principles are population-based, measurement-based treatment to target, patient-centered care, evidence-based treatments, and the 5th one is accountable care. So it's important to have metrics that kind of line up with those 5 key principles. So that first principle, population-based care, as part of developing a collaborative care program vision for your healthcare organization, you want to identify the focus population to work with. So one of the things you may want to do is measure how well you're reaching that population with screening, so you can identify who needs care and get them enrolled in treatment. And for health equity purposes, it's a good idea to look at this and the other data and talk about race, ethnicity, language, and age, and other health equity markers. So some individuals get nervous about separating the data out, but if you don't, you will have no way of knowing what is going well and what needs some work based on these different indicators. So although that is called out for a couple of metrics, it's really an overarching analysis that should be a part of metrics monitoring. The second thing healthcare organizations may want to measure is access, how long it takes between a positive screen for the PHQ-9 or GAD-7 and that initial assessment taking place. Similarly, they may measure time from the initial assessment to the first follow-up. So we know from published literature that patients are more likely to improve when that first follow-up is within 30 days of the initial assessment. So it's also good to track the proportion of eligible patients who are actually enrolling in collaborative care. So there are a number of studies that report on this for programs that serve diverse patient populations. The average that is reported is about 50%, though cost share issues can kind of drive this up or down. This is something for you to consider as a payer. Another factor that can influence enrollment and engagement is how patients are identified. So programs that do case findings through electronic means only, rather than screening and referral from the PCP, they may typically have much lower enrollment and engagement rates than if they were finding patients through electronic means and getting referrals directly from the PCP and doing screening and things of that nature. So it can be helpful to measure your caseload reach. To us, there should be a front door to collaborative care and a back door to collaborative care. It doesn't matter which way patients are coming through. So you want to make sure that there's not just kind of tunnel vision on that. Patients shouldn't be kept on the caseload indefinitely, which is why we have relapse prevention and why that's so important. It's also why good registry helps identify patients who may be ready for relapse prevention. So it can be hard for a behavioral health care manager to let go of patients, self-included. I've been a behavioral health care manager, so it's hard sometimes to let them go. You know, the patients that you like and the ones you've made really good connections with, but there are other patients who also need help, and staffing resources are not infinite. So we need to make sure, you know, we're looking at the registry, who's ready for relapse prevention, some of those things. And finally, looking at the frequency of contact could also be really helpful. So the behavioral health care manager should strive to have at least one contact per month, as I mentioned before, with their patients at a bare minimum, but also more frequently when symptoms are more acute. So many organizations, they strive and their goal is for 2 contacts per month until the patient has a relapse prevention plan, which will happen when the frequency of those contacts can drop once the patient is showing some improvements. So suggested targets for these metrics are shown in the right-hand column here underneath target for some of these different indicators that I discussed. The second principle of collaborative care is measurement-based care. So measuring the proportion of contacts that include a symptom measure can sometimes get left behind when developing a metrics dashboard or print out reports from your EHR. So it's easy to assume that these are being done regularly, but sometimes we see a gap between expectations and what's actually happening. So sometimes we hear from behavioral health care managers that patients don't want to fill out the measures repeatedly. In our experience, if the behavioral health care manager helps the patient understand that these symptom measures are equivalent to when you come to your medical provider and get a blood pressure taken, if you're treated for hypertension, then that can help patients get a better and faster understanding of why, and that helps the team to be able to adjust the treatment. So explaining all of that to the patients, they're usually then more willing to do them. It can also be the case sometimes that the behavioral health care manager may not feel comfortable with quantitative measures as a part of treatment. Some of us that have gone through, and I can say us because I've been one. Some of us, you know, we didn't get a lot of training in graduate school or training in school in general around looking at quantitative measures. So many behavioral health care managers are just not trained to use that kind of symptom rating scale and looking at measures as a part of their training. So that could be challenging to adjust for some, not all, to adjust to looking at things that way. But you can't do treatment to target if you don't have some type of measure, or if your measures are out of date because you're not getting them routinely, then there's no way to do to meet this principle of measurement-based treatment to target. So these metrics also relate here to measurement-based care. Quickly identifying when treatment needs to be adjusted is one of the cornerstones of collaborative care. So metrics are essential in helping the treatment team accomplish this. So one of the most important components of any collaborative care program is the systematic caseload review. So these meetings should happen weekly, even in the beginning when the program is just getting started and maybe you don't have, you know, that many patients, things might be a little bit slower. But when things are slower in the beginning, the psychiatric consultant and the behavioral health care manager That gives them some time to get their rhythm down. The behavioral health care manager will learn what information the psychiatric consultant needs to make their recommendations. Being consistent instead of ad hoc with your meetings is also absolutely essential. Initially, there will be plenty of time to talk about all the patients because in the beginning, your caseload is just really low. But it is important for the psychiatric consultant and the behavioral health care manager to get their rhythm and their timing down, to get their flow down in those early days, so that as the caseload starts to grow, you're able to be more efficient with your time, because you could talk about 6 to 10 patients per hour. So this requires the behavioral health care manager to be prepared with a succinct summary of the information that the psychiatric consultant needs to make meaningful recommendations to the team. And as the caseload grows, it will be important to be efficient and to have a registry that helps you to quickly identify the highest priority patients for the systematic caseload review time. Because if you have 90 patients on your caseload, you cannot go through all 90 patients in an hour a week. So you want to make sure that your registry has a way to identify those high need patients. So to accomplish this, the registry should keep track of the length of time since the last case review, the systematic caseload review that happened, and whether the patient is at least 50% improved since baseline. So when the caseload is full, it gets tough to kind of quickly identify this without some tool to calculate. And we've seen lots of different tools. There is the AIMS caseload tracker that we have, but individuals are building their own in their registries in different different types of EHR. We've seen some really innovative things happening out there. So you just want to make sure there's some way there to identify that. You want to know what proportion of patients engaged in treatment have experienced response or remission, and whether this is as expected or not. And then it can also be helpful to keep track of this, not only for your current kind of active caseload patients, but also looking at historical data. So you could see what the trend looks like over time. And then being able to identify those trends, then you could say, okay, is it getting higher? Is it getting lower? What things might we need to adjust in our service delivery in our collaborative care program? Patient experience is one of the elements of the quintuple aim. So increased satisfaction with care has been shown with collaborative care. You know, as I mentioned earlier, patients receiving collaborative care were significantly more likely to be satisfied with their depression care. So you do want to look at that. And then the fourth principle is evidence-based treatments. This is perhaps one of the more challenging metrics to track, but it could be important, especially if the behavioral health care managers are accustomed to providing longer term or kind of open-ended treatment or therapy. Sometimes people call it traditional therapy. So even though they may be trained in evidence-based techniques, it can sometimes be easy to engage in general supportive counseling rather than actually using an evidence-based proven technique. So it can be challenging to track this because the mode of treatment may be embedded within a text note in the EHR. But if healthcare organizations can track this and figure out how to track this, it will be really helpful. And then the fifth principle is accountable care. Accountability is not all about money, even though I mentioned earlier we are a business, but it is not all about money. So from a healthcare organization perspective, you want to look at how well do your processes and outcome metrics align with your vision, your goal, and the expectations that you've set for your program. As a payer, are you achieving the expected cost savings that you initially projected? So that's important to loop back around and look at those things as well. So New York Medicaid has made a big investment in collaborative care for almost 10 years now, and they've learned a lot. If you talk to some of the individuals from New York, or you've been on any of the webinars out there, that they've done. You will know you'll know they've done a lot of things and they've learned a lot of lessons along the way. But this shows some of the factors they found to be important when comparing clinics that successfully implemented and sustained collaborative care as compared with clinics that were not able to successfully implement and sustain. So some of the strongest indicators they found were that strong patient engagement was important. So like even clinics that were able to do warm handoffs, a strong screening, referral, workflow, standardization of that. So some written workflows. So sometimes we say, yeah, we have workflows, but if someone new comes into the team, they don't know it. So standardizing that process, that was something that they had. Another thing they had on there was adequate personnel. So having a full-time behavioral health care manager. We do have a lot of systems that the behavioral health care manager wears dual hats. Maybe they're doing PCBH and collaborative care. We've seen it, it does happen. But what they have seen is those that have been able to be more successful have been those that have had a full-time behavioral health care manager. That training has to be ongoing, not just at the beginning when you're planning the program and you're implementing, starting to implement collaborative care, but it needs to be ongoing throughout. That there needs to be effective use of the registry, working with IT. You want to align any of the factors that come from higher up, so leadership, C-suite, any of the things that they are concerned about, you want to make sure to align it with your program. You want to leverage your funding, and then of course that accountability piece to be able to use the metrics, audit your program, get feedback from patients, from providers, from behavioral health care managers, all of that. And then some of the barriers included inadequate time for personnel to do their role, poor patient engagement impacted things, poor provider engagement, competing initiatives, challenges with workflow and screening, and lack of funding. Lesson 6 that we've learned over the years is about the systematic caseload review. I mentioned we title it SCR, that is essential, and it's essential to having an effective functioning collaborative care program. It's also a key component of collaborative care. So it's that meeting between the behavioral health care manager and psychiatric consultant that happens weekly. It's typically an hour, but depending on your caseload size, it could be longer. A good registry will facilitate helping in that meeting between the behavioral health care manager and psychiatric consultant. It'll facilitate helping identify patients to talk about, priority patients that are more complex, diagnostically complex, those who may be ready to end an episode of care, those who are improving adequately and just may need a treatment or not improving adequately and might just need a little treatment adjustment. So this system, the registry, being able to do that. And the primary purpose of SCR is to support measurement-based treatment to target. So if the treatment plan started with medication therapy as a primary treatment, the adjustment might be a change in dosage or adding on an evidence-based brief treatment. If the treatment plan started with evidence-based therapy, the adjustment might be adding in medication or changing to a different intervention. So each treatment plan should have about a 10 to 12 week shelf life. If the patient is not at least a 50%, showing a 50% improvement, something should be changed. So this prevents the kind of clinical inertia that we found sometimes in usual care, where some of the key factors of the patient not improving can sometimes be overlooked, and there needs to be a change that happens pretty consistently or regularly based on how the patient is responding. So what do we see as the future direction for collaborative care? So it exists within an entire ecosystem of behavioral health care. It is not designed to be all things for all patients. So at the bottom of this pyramid is patient self-management. This could include a lot of digital therapeutics. We are seeing a lot of expanding in the realm of AI, use of artificial intelligence for integration. So there's also in this the lowest tier, which is just primary care on its own. Increasingly, primary care providers are feeling more comfortable in treating that mild to moderate behavioral health condition on their own. But the key is to recognize when the patient needs a little bit more support than what the PCP can provide by themselves. But we are seeing more PCPs that are feeling more confident in treating on their own without that additional assistance. And then the next tier up includes collaborative care and other integrated care strategies like primary care behavioral health. These are two models, collaborative care and PCBH, that address different patient needs and function differently in primary care. But they both are there and exist and could work well together. It doesn't have to be a one or the other. It could sometimes be a both and. So in PCBH, the behavioral health consultant aims to reach the entire clinic population rather just than looking at a subset of patients that have a diagnosed mental health condition like depression or anxiety. And so that BHC, behavioral health clinician, strives to intervene with all patients on the day that they are referred, doing warm handoff. They too have some focused 15, 30-minute visits to assist with specific symptoms or functional impairment. And, Jeff Ryder, who's one of our colleagues in 2018, gave the definition of PCBH as biopsychosocially influenced healthcare conditions is the focus. And so there are a lot of clinics that we're seeing now that are doing both. When resources permit, it could be ideal to definitely offer both because they address different patients and the full range of behavioral health needs that come up in a primary care. So when you could do both, please do. So that is something else that we're seeing happen. And then at the top of the pyramid is specialty behavioral health settings, either within the healthcare organization or in the community. We're seeing more evidence out there for collaborative care being effective with adolescents that have depression as well as children with ADHD. So we're seeing a lot of research. There's some research by Richardson and Shippey that showed a significant difference in depression response or remission between collaborative care and usual care for patients age 12 and older. There's some studies by Myers and colleagues that show collaborative care to be effective for Latina children with ADHD that are being treated in pediatric or family medicine settings. And then most recently, there's been this big explosion of interest in using collaborative care in general pediatric practices for a diverse range of conditions, including behavioral problems with younger children. So there's some significant evidence that's coming out there. So the AIM Center, we published a pediatric collaborative care implementation guide that's on our website for anyone who's interested in that. And there's also a quarterly webinar we'll be doing on pediatrics in April because the topic is blowing up. Some of the key points that were in the guide that we created is that collaborative care is needed in the pediatric setting. You need to be able to address emotional and physical development concerns and that intersection between behavioral health and medical conditions, including family issues. So being able to support and or provide interventions there. There's a report out there from Meadows Institute that found that advancing policy ensures that individuals enrolled in state Medicaid programs have coverage for collaborative care. So we encourage individuals to advocate in your state if you don't have collaborative care yet in your state. We've seen a lot of analysis of case studies in New York and North Carolina and Texas and Washington. So we're going to be seeing, I think, much more of that. There's perinatal collaborative care that is also, yes, I say emerging, but there are a lot of people that have been doing it and starting to put some of their research out. We have seen that the suicide rate has been estimated to be between 2 and 4 deaths per like 100,000 live births, and it's been the leading cause of mortality in people in the first 12 months of postpartum. And so collaborative care is a definite model that should be in that space. In one of the studies, collaborative care for perinatal patients, 48% achieve or sustain remission of symptoms. So we're seeing more done in that realm. We're actually having a webinar on perinatal collaborative care happening January 16th, because it again is one of those booming topics. And then we're also starting to see collaborative care in specialty settings with diabetes, coronary heart disease, cancer, lots of studies that are out there, and systematic review and meta-analysis that have been happening. Again, that link I showed in the beginning, we have a lot of additional links to some of the emerging data that's coming out. Just wanted to mention, there was a recent randomized controlled trial by John Fortney and some colleagues that compared the effectiveness of 2 approaches to telepsychiatry on improving the quality of life among patients with complex psychiatric disorders being treated in rural primary care clinics. The patients had depression as well as bipolar, PTSD, or both, and there were randomly controlled trial. And so at 12 months, patients in the 2 groups both experienced large and clinically meaningful improvements in their symptom scores and quality of life. So we're starting to see more happen in the telerealm with collaborative care. So of course, more complex patients in collaborative care need more resources. The IMPACT trial, as I mentioned, actually had patients in it that were more moderate to severe symptoms. There's a SPIRIT trial where patients have direct access to a psychiatric consultant at the initiation of treatment. So we are seeing some research, some data coming out about different programs that are having where maybe the psychiatric consultant sees the patient initially, and then it's all done through the systematic caseload review. So we're just seeing some variance in how some of that is taking place. I think we'll see more of that. And there's some reviews that are out there that are more time frame things that are coming up from the SPIRIT trial as well that we'll be sharing when that is done. So payers and policymakers play a significant role in the adoption of the uptake of collaborative care. So again, we recommend that individuals advocate for collaborative care to be a part of preventative services, and looking at some of the cost savings associated with collaborative care, asking your policymakers to maybe defray some of the startup costs, which is usually the most significant cost that happens, and proposing that maybe there's a stepped payment rate or something of that nature. So Meadows Mental Health Policy Institute is doing a lot of work around this as well. So we just encourage people to collaborate, get together, work together. The more that we advocate as a collective group, the stronger that we are. So we encourage individuals to talk and collaborate and learn the lessons from other states and other clinics as you are embarking on this collaborative care journey. And I just realized I talk a lot, but I am here to take questions.
You are fantastic, Monica. Wow, that was extremely thorough. And loved how you talked about the pillars and talked about the metrics, right? That's key. I am watching the clock, and we do have time possibly for a question or 2.
Hi, this is Cherie Brown from Community Health Centers of Arkansas. And my question would be, how would we be able to utilize or integrate the community health workers in this process?
Absolutely. That's a good question, Cherie. And now we even have Medicare just came out with their rule that includes some coding and funding that you can get for community health workers. So one of the things that we oftentimes talk about is shared responsibilities and roles, because we recognize that a lot of clinics have additional staff. It's not just the behavioral health care manager. So you can do collaborative care, you can do PCBH, you can have community health workers that are all a part of that. We've worked with some clinics that also have dental programs. Like there's a lot of things that are out there. What we encourage individuals to do is to be really innovative about how all of those individuals are collaborating together. Because the one thing you don't want is individuals doing double work or overwhelming the patient. So this is where sitting down and having some conversation about scope, about what services that you'll be providing in the clinic, and creating those workflows that are really detailed are really necessary. But community health workers, that is coming up not just at FQHCs, which is I think where most people are typically used to seeing them, but they're coming up in a lot of primary care clinics. And I think that's the reason why now they're starting to be coding and funding geared towards community health workers.
Thank you.
Absolutely. Thank you for your question.
Okay. Thank you, Monica. It is 9 o'clock. So I want to go ahead and in closing say, I know there's lots of questions, probably swirling around, and COCM is a topic that we are going to continue working on. We have had a couple of webinars on COCM and we'll continue to have them. I do want to just shout out and say, Monica mentioned that she's doing a perinatal webinar January 16th. The AIM Center also has monthly office hours for billing questions, and then they have a monthly office hours for implementation. And so know there are plenty of resources out there. Aben's going to be doing some work on this as well in Arkansas. And no, COCM is here to stay. It's such an important piece of healthcare. As you could hear from Monica, patients are getting better. They respond well. They like this. Care teams are responding well. They like to be participating in models where integrated behavioral health is happening. And then, of course, showing those cost outcomes is really, really important. So with that, I want to thank everyone for their time. We want to be respectful. We know it is 9:01. If there are burning questions that you have, please send them my way and we will get them to Monica. Thank you for your time. In February, we will be having Christopher Brott with the AMA, and he'll be talking about integrated behavioral health and the behavioral health compendium that they have. So please join us in February. We are excited. And Monica, thank you again. I plan to be on your webinar on perinatal care, and I will see you then. Thanks, everyone. Have a wonderful day.